So Professor Nilesh Mohan is a senior ophthalmologist at Regional Institute of Ophthalmology at IGIMS Patna, and he will be speaking on it boils down to accurate biometry, because this is the most important fact when you're putting premium eyes. Dr. Nilesh Mohan, please.
Good morning, everyone. At the outset, I would really thank the Scientific Committee of All India Ophthalmic Society and APO and my chief instructor, Dr. Satyajit Sinha, for having me here. He had spoken about the use of premium lenses. So basically, this topic has been given because it really boils down to accurate biometry, because you are counseling the patient for premium lenses, and if you have drastic results or surprises, that's a concern. So why is it important? Because we are using premium lenses and the patient's expectation have gone high, and nowadays the cataract surgery is being done as a refractive cataract surgery. So the biometry, what do we do in that? It's a measurement of the corneal power, the axial length and other ocular parameters, and the IOL formulas to achieve emetropia. So in keratometry, we have options of manual, we had automated, we have optical biometers that do take keratometry readings, topography-based readings, and Schemflug imaging system-based readings. So keratometry should be done before any contact procedure done on the cornea as well as the axial length for both eyes. Now, various manual keratometers and various other automated keratometers also show different points, and basically you have to be consistent in using one of the keratometers to have a consistent result. The data validation is usually done if you have to remeasure. It's a standard teaching. If the K reading is less than 40 or more than 47, or the difference between the corneal cylinder is more than 1 diopter, or there is a difference in the corneal cylinder and the refraction cylinder, then you need to remeasure it. Now, the sources of error in keratometry could be an unfocused eyepiece, failure to calibrate, measurement off axis, patient not fixating, dry eye patients. These are all factors should be kept in mind while you're going for the readings. Now, coming to the axial length measurement. The standard is the ultrasound measurement. The contact procedure is the standard one, easier, cheaper. There are disadvantages associated with that. That can be rectified with the use of immersion, contact immersion. You will have more predictable results. And the optical one, which have come, you have different biometers, Almaster 500, 700, Lenstar 900, and different biometers are there. They are definitely advantageous, more accurate, but very costly. And in hazy medias, it may cause an issue, but the newer biometers have taken care of these things. So principle of ultrasound biometry, you all know that there is a piezoelectric crystal. Usually there is an ultrasound velocity, the electrical signals and are picked up, and various structures emit different signals, and you get a quality A scan. Now you have an electronic amplification. You have a gate. You increase that when you are not able to visualize properly. Now, gates are basically electronic calipers for measurement between the spikes. When you have any doubts, you have to have correct measurement of the gates. Measurement, as I already told you, is based upon the ultrasonic velocity in different structures. The cornea is not routinely factors because it's too thin. Now, A-scan validation again is done if the measurement it has to be remeasured if your axial length is less than 22 or more than 25, or there is a difference between more than 0.3 in both eyes, or you have a problem with the fixation, or there is a difference in the refraction. So when a remeasurement is done, definitely it should be done without bias. One should not be knowing what error is coming. Now, in coming to the optical biometry, they are based on different principles: laser interferometry, partial coherence interferometry, and optical low coherence reflectometry. They use different biometers, use different technologies and the source. So this is a list of the biometers available, which are based upon different technologies: partial coherence interferometry, OLCR based, and swept source OCD based, and the use of those things. Now, comparison of IOL Master and Lenstar is shown in the picture. You can see that how the newer generation biometers are trying to be more accurate and measure different variables which are required for a more accurate IOL power calculation. Comparison of IOL 700 and Lenstar 900 have shown comparative results. Now coming to the IOL formulas, we have different generation of IOL formulas available. First, second, third, fourth, and fifth generation formulas, we all know that. But recently, Cox et al. Suggested a new classification of IL power formula based on method of calculating IL power and data used for these calculations. This is historical or refraction based, regression analysis based, the SRK and SRK2, Vergence formula based on Gaussian optics, 2 variable Holiday 1 SRKT hover Q, 3 variable Higgins LEDARs, 5 variable, 7 variable, artificial intelligence based and ray tracing based. So the parameters required for the calculation of important IL power formula are shown in the picture. So which formula to use? So in all ranges, you can use Holiday, Olsen, Barrett, Universal, 2 Higgins, but 22 to 24.5, you have all modern formulas. Shorter axial length eyes, you require Hofer Q. Larger, you require Holiday. So, but Holiday 2, Olsen, Barrett's 2, and Higgins can be used in all segments. Minus power lenses, Higgins is the best to measure. In low powered plus lenses, SRKT, Hofer Q, Holiday 2, and Higgins is good. You have to be very careful in IL power calculation in special situations like children, post-refractive surgery, silicon-filled eyes, and while implanting piggyback lenses. So these are the situations where you come to the newer generation formulas. They are more predictable. But despite all those things, why we need to optimize? Because there are different surgeons have different surgical technique. Others are using different biometers. Just 30 seconds. The size of the CC varies. There could be inadequate visco removal, capsular fibrosis, lens bag shift. So to conclude, I would say that we are still trying to achieve emetropia. The things are evolving. We have come to a stage where we are delivering very good results. Though the IOL powers are available in 0.5 step diopter steps. So I would say it's always the man behind the machine, how you're operating, how consistently you're using one machine and giving predictable results. So biometry definitely is very, very important when you are in the segment of premium IOLs. Thank you.
Thank you so much, Dr. Nilesh Mohan, for that wonderful presentation. One thing which I wanted to ask is the posterior keratometry, like in IOL Master 700, which is an upgradation from the 500. How important do you think it's absolutely for us to use in our day-to-day practice? Because we all know by now that posterior keratometry is important, but it's not very affordable by everybody. So how important is that role of IOL Master 700 for posterior keratometry?
It is, but when the calculation, when the comparison between IOL Master 700 and Lenstar 900 was there, the variables of effective lens position becomes more important.
Okay.
So that they have shown that ELP becomes a more important factor. So
Okay.
see, what I said is that when you are measuring more variables, you are calculating the IOL power with the modern formulas in a little more predictable way. That doesn't mean that if you are not having those, you are going to give a surprise all the time.
Mm-hmm. Okay.
We have a Barrett model which has a pre-calculation for this posterior corneal curvature, and they adjust the elements based on the other findings with the rule and against the rule. They have some adjustments. It assumes.
There is an assumption. Everywhere there is an assumption in all the formulas, but more accuracy is there in the Barrett's too.
There was a study.
इसको माइक को ऑन कर दीजिए. May I request Dr. Subhash Prasad sir and Dr. Nagendra Prasad to please join me on the chair here?
There was a study. They have measured the PCA, posterior corneal astigmatism, by 3 instruments: IOL Master 900, Pentacam, and one was. So they see that they are giving different results.
Yeah.
So predicted PCA value by Baylor nomogram, it is better in some cases. In some cases, measured is better. When refractive surgery is done, you can't predict. So then in that cases, measured, you have to take measured PCA. Otherwise, predicted PCA value, which is incorporated in the toric calculators, is sufficient. So they are using Baylor nomogram.
Thank you.